Good afternoon, everyone, and welcome. Thank you for joining the next level of breakthrough technologies in ultrasound imaging. I am Anne Jet, and I am the European Product Manager for Hitachi Medical System. We would prefer to see you in real life, but anyway, we are very glad to introduce you our new ultrasound platform, Arieta 750, and two very interesting clinical lectures. The first one is about liver disease assessment, and the second one about renal and fusion imaging. But before and first of all, we are very proud to release our new Arieta 850 ultrasound platform. So now, Luca, can you just give us some information regarding the first speaker, Dr. Giovanna Ferraioli?
Okay. Good afternoon, everybody, and welcome to our webinar. We're very glad to have here with us Professor Giovanna Ferraioli. She's from the Infective Disease Department of Policlinico San Matteo in Pavia, in Italy. Professor Ferraioli is a very well-known researcher in the field of elastography, especially for diffuse liver disease. She also has a very strong knowledge about all non-invasive assessment of liver steatosis and contrast agent. She's very well known worldwide. She is a member of editorial board of European Radiology, World Journal of Gastroenterology, Journal of Ultrasound in Medicine, and many more. Today we are very happy to have her to give us a lecture about non-invasive assessment of liver fibrosis and steatosis with ultrasound-based technique. So thank you very much, Giovanna Ferraioli. I pass the microphone to you. Thank you.
Thank you, Luca, for this kind presentation. I'm trying to move. And shear wave elastography has been accepted by guideline as a reliable substitute of liver biopsy in several clinical scenarios. And nowadays, shear wave elastography is used instead of liver biopsy. And it is important to note that the Bavino conference has proposed a new term in case of severe fibrosis, the F3 stage, and liver cirrhosis, the F4 stage, because the spectrum is a continuum in asymptomatic patients. So it is not possible to distinguish between the two on clinical grounds. And for that reason, the term compensated advanced chronic liver disease has been proposed. And the ARFI-based techniques on ultrasound equipment, either point shear wave or two-dimensional shear wave elastography, all the studies, they have shown that these methods have an accuracy compared to transient elastography similar or higher. For sure, there's a higher applicability. It is in case for performing shear wave measurement, it's important that the patient is in fasting status because there's an increase of the blood flow, an increase of stiffness after eating. The intercostal space is used in a supine position. In a resting respiratory position is a breath hold without a deep inspiration, and also to avoid artifacts, the region of interest should be placed at least 1.5 centimeters, 2 centimeters below the Glisson capsule. We should avoid the large vessels because there are artifacts, and also when we use transient elastography and point shear wave elastography, it is recommended to use the median value of 10 measurement together with a quality factor that is the variability between measurement. The interquartile range over the median should be up to 30%. In case of two-dimensional shear wave elastography, 5 measurements are enough, the same quality factor, and it's important also to have the availability of manufacturer's quality criteria. The quality of the beam of the image is very important. And to look for the quality of the beam of the image, we look at the liver capsule that should be seen on the screen as a clear white line. Measurement of liver stiffness should be performed by experienced operators. When we use the e-touch system, in each single measurement is made with up to 5 push-pulls. And on the e-touch system, for the shear wave measurement, we have a reliability index that is the VSN, and the VSN must be higher than or equal to 50%, at least 50%. We have assessed the cutoffs for ruling in and ruling out significant fibrosis and liver cirrhosis in patients with chronic hepatitis C in a series of more than 500 patients using transient elastography as the reference standard. And as you can see, there was a high accuracy of the method in assessing significant fibrosis and liver cirrhosis, and these are the cutoffs for ruling in and ruling out F2 stage and F for liver cirrhosis. In our series, we have confirmed that the interquartile range over median is a very important quality criterion. In fact, the performance of the method was very high when this quality factor was respected, and it was lower in case of interquartile range over median higher than 30%. There are confounding factors when we assess the stiffness. This is because we are assessing the stiffness that is related to fibrosis, but may increase also due to other factors. Acute hepatitis that is associated with the transaminase flare. For this reason, we should always take into account the necroinflammation, and results should be evaluated in the clinical settings. Also, there is an increase of stiffness in infiltrative disease, such as amyloidosis or lymphoma, in congestive heart disease, after eating, in extrahepatic cholestasis, and also in deep expiration. So it's important that the patient breathes normally when we are looking for the area where to perform the measurement, and then just stop breathing when we are ready to perform the measurement. There are sources of variability. The measurement depth is one of the most important, and the results with the lowest variability are obtained at a depth of 4-5 centimeters from the transducer. The position of the transducer should be in the intercostal space and perpendicular to the liver. the operator experience, as I said before, the operator experience is very important when we perform two-dimensional shear wave elastography. Other sources of variability are dependent on the patient, the position. The patient in a supine position is the one used in the most published studies. The respiratory phase, deep inspiration affects the measurement, so it's important the quiet breathing and then stop to breathe for very few seconds when we push and we launch the measurement. The fasting state, because eating increases the stiffness, but also the fibrosis stage. At the lower stage of liver fibrosis, the reproducibility may be lower because there is an heterogeneous distribution of liver fibrosis that should be taken into account. And in case of liver steatosis, there are conflicting results between studies, but for sure it is more challenging to perform the measurement in case of severe steatosis, and this is due to the attenuation of the ultrasound beam. There are guidelines, several guidelines released by the European Federation of Societies of Ultrasound Medicine and Biology, and these were the first guidelines 7 years ago. And the World Federation also has issued guidelines. The Society of Radiologists in Ultrasound released a consensus in 2015, but also clinical guidelines. The most important is the European Association for the Study of the Liver, together with the Latin American Association for the Study of the Liver in 2015. All these guidelines, they recommend to use shear wave elastography to stage liver fibrosis, mainly in patients with a chronic viral hepatitis, but also in patients with non-alcoholic fatty liver disease. The European Federation has updated guidelines in 2017, and also the World Federation updated the guidelines. And on the updated guidelines of the World Federation, the rule of 5 for transient elastography has been endorsed. The rule of 5 starts from 5, below 5, using transient elastography, the patient is normal. At below 10 kPa, we can rule out compensated advanced chronic liver disease that includes F3 and F4 stage. At 15 kPa, to rule in compensated advanced chronic liver disease, and below 20 kPa, to rule out varices needing treatment. The Society of Radiologists in Ultrasound have updated the consensus. It has been submitted to radiology and it will be published in a few months. And mimicking the rule of 5 and taking into account all the published studies, we have proposed the rule of 4 for patients with viral hepatitis and non-alcoholic fatty liver disease. Below 5, like with transient elastography, high probability of being normal. Below 9 kPa, we can rule out compensated advanced chronic liver disease. 13 kPa to rule in compensated advanced chronic liver disease, and above 17 kPa, this value is suggestive of clinically significant portal hypertension. Could you please go to the next slide?
Now you can, Giovanna. You can click.
Okay, thank you.
Please continue.
I'm sorry, it's not working anymore. Could you please? Okay, thank you. And another recommendation of the consensus is to use the delta change of liver stiffness over time instead of using the absolute value to follow up a patient. But in case of viral hepatitis, we suggest to use as a baseline value the one obtained after viral eradication or viral suppression. And the clinical significant change should be considered as a change that is at least greater than 10%. And this expert opinion that this rule can be applied also in pediatric patients. In this case, each subject becomes its own control over time. And non-alcoholic fatty liver disease, now that we have effective drugs for the treatment of patients with viral hepatitis, is becoming the major cause of chronic liver disease. And the degree of liver steatosis is linked to the metabolic syndrome and cardiovascular risk, but also it has recently been reported that the significant steatosis is associated with the progression of fibrosis in patients with non-alcoholic fatty liver disease. And for that reason, it is important an accurate estimate of the quantity of fat in the liver in the workup of patients with liver steatosis. On the ITACH system, there's the availability of a software to evaluate and to quantify the attenuation of the ultrasound beam. It's an attenuation coefficient that calculates the amplitude difference of the received signals in two frequencies. And the use of this double frequency is important to eliminate all the effect to the structure or artifacts due to vessels or variation in the brightness. This method, in a series of more than 300 patients, has been correlated with the fat in quantity in liver biopsy. And as you can see, the correlation was pretty good, and also the accuracy of the method. In another series, preliminary results in almost 100 patients with chronic liver disease, the cutoffs have been obtained. Cutoffs to stage, to quantify steatosis and detect steatosis starts from 0.68, and the results are given in decibel per centimeter per megahertz. On the report, we have the possibility to see each measurement we have performed, both for the stiffness and for the attenuation. And for the stiffness, the results are given in meter per second or kPa. What we use at the end is the median value together with the AQR divided by median. And this value should be up to 30%. And you can see here that there is the median value of the elasticity and the median value of the ATT as well. So in conclusion, the ultrasound systems are widely used for the screening of patients with chronic liver disease. It is possible to obtain a thorough evaluation of the liver. Instead, if we use the fibroscan, we have the possibility only to have a value of an assessment of fibrosis and steatosis. With the ultrasound equipment in the diagnostic workup of patients with chronic liver disease, there's the possibility of a multi-parametric approach. The body image together with Doppler, contrast, elastography, and attenuation coefficient. I thank you very much for the attention. Sorry for some trouble during the presentation.
Dear Professor Ferraioli, thank you very much, because it was really interesting. Thank you very much for everything. Don't worry for the technical problem. I think everything was fine. As far as I see, there are some questions that maybe we see very quickly now. It was very interesting to see how this technique can help the assessment of liver fibrosis and steatosis. One question was about how important is the use of the non-invasive technique for assessing diffuse liver disease? Is biopsy still needed?
In patients with chronic viral hepatitis and non-alcoholic fatty liver disease, it has been accepted by guidelines that a non-invasive method can reliably substitute liver biopsy. In our experience, I'm working in an infectious disease department. We do not perform liver biopsy anymore in patients with the chronic hepatitis C and chronic hepatitis B. On the other hand, it is important to assess the patient clinically and not to stage exactly liver fibrosis using the biopsy. It's important to understand that F3 and F4 stage, they should be combined together, because patients in F3 stage, they are already at risk of complications related to liver disease.
Okay, thank you very much, Professor Ferraioli. Thank you for your time. And I think we can pass to the second speaker, to Marta, that will introduce the second speaker, Professor Correa. Thank you very much.
Hello, everybody. We are very glad to introduce you Professor Jean-Michel Correas, who is a very experienced radiologist, mainly focused in advanced imaging solutions related to urology and liver disease. Professor Correas is the Vice Chairman of the Adult Radiology Department at Necker University Hospital in Paris. And today, he will share with us his experience about renal and fusion imaging with Arietta 750.
Yes, good afternoon, everywhere. It's a great pleasure for me to be here and to share our experience using the new platform Arietta 750. So I'm moving the slide now, and basically, you know, interventional radiology is taking a growing role in many aspects for ultrasound guided biopsy, for nephrostomy, drainage, and tumor ablation, of course. And guidance improvement is the key for improving the results of these procedures. And ultrasound is playing a key role for lesion identification and the vascular relationship of the lesion to the surrounding environment, and particularly for needle insertion. Visualization of a needle track and the needle tip is also a key for having a very safe procedure. And of course, at the end, we just love the possibility to combine information from ultrasound and CT, and this is done through fusion imaging, and fusion imaging has been very much improved with the introduction of automatic tracker techniques. So clearly, ultrasound guided procedure have a major advantage, and this is real-time imaging technique. And so as you can see here, in this case of a very difficult biopsy, as the lesion is really center, you see the needle advance toward the node, and getting the sample in a very safe situation while the case is really difficult. Ultrasound has also advantage of a high spatial and contrast resolution, very large availability, having non-toxic and being mobile. And we can also use Doppler for vessel identification an ultrasound contrast agent administration for a vascular assessment. Of course, we know that there are some limits, and sometimes the lesion identification is very complex in the postoperative situation. The needle track imaging can be difficult in obese patients, and limited imaging quality after surgery, biopsy, and evaluation of surrounding structures. And as you can see here, the needle was positioned in a very very long approach in a very deep patient. Of course, there's no question of fighting the two techniques, ultrasound and CT. And we know that CT has a clear advantage in terms of spatial and contrast resolution if we use mainly a contraster agents, needle track visualization, and limited operator dependency. But we know very well the limitation of CT, and that's no real-time imaging besides CT fluoroscopy, the need of iodinated contrast media administration. It's time consuming. We have metallic artifacts. So, and at the end, of course, radiation exposure. So when we're targeting very deep lesions, as you can see in this case, the needle was positioned, in a very oblique way, and you see how well the result with ablation you can have in this case. So really putting advanced imaging features in new ultrasound platforms is critical. And you see here that we can do some shear wave point measurements. We can also use advanced Doppler techniques that really mimic and feel the Doppler lumen, the vessel lumen, or also detect very slow flow inside kidneys, for example, as well as in hypovascular tumors. And at the end, we would love to use all of these techniques together with the fusion imaging. So let's see a very simple case of a patient coming for a suspicion of a small renal mass that was incidentally reported. But the renal mass is very difficult to see, here at the pole of the kidney. And the use of contrast, of course, is critical as you will be enhancing your diagnostic capabilities. And this is very well shown in the literature. And you see how well we can see now that this is a true mass. This is not just an artifact or a pseudo tumor. This is a true tumor. And you see the correlation with the MR that was performed a little later after the contrast enhanced ultrasound examination. So this is another case of a patient with this hypoechoic hypovascular mass. And the question was, is this a hemorrhagic cystic lesion? And basically, you just inject contrast and you immediately can see the enhancement of the lesion with a very strong enhancement, just confirming the presence of this lesion that is not anymore hypovascular as evocated by the Doppler examination, but truly hypervascular as displayed with the contrast administration. So moving now to, and this was a chromophobic renal cell carcinoma. The advantage of good ultrasound techniques is that we can characterize even very small lesion as these hypoechoic area that was detected or suspected during the MR examination of this renal transplant. Basically, a very good image quality can just suffer by itself, and you see that this is just a subcapsular cyst. And incidentally, we also discovered a mild renal artery stenosis in this renal transplant. So good image quality is still the key for interventional procedures. And this is a very large fatty lesion in the retroperitoneal space. And you see that we can do guided biopsy in a very safe situation. And this was hyperechoic retroperitoneal lipoma. So being safe is the key, and of course the use of fusion imaging is exactly moving to that area. At the start, it was just a combination of a PET-CT, PET-2 CT or MRI, and the technique has been extended recently to ultrasound with the additional challenges, of course. The principle is quite simple because we just superimpose the ultrasound information to CT or MRI data to take advantage of the both techniques. Ultrasound with the real-time imaging, spatial resolution, and being mobile, and CT or MRI with a contrast resolution and overall evaluation of the disease. So with these two techniques, of course, we can improve guidance and improve the safety for very complex interventional procedures. Basically, there are three different techniques for doing this fusion imaging. So we can use registration or synchronization that is cognitive. So basically, you just look very carefully to your CT or MRI, just move to the ultrasound room, and then do the procedure. And then now we have next generation, I would say, techniques that are using software fusion. For fusion, we can use all anatomical markers, and this is just by simultaneous identification of same structures on the CT or MRI or ultrasound. Or now we can even use much more advanced technique, much simple and faster techniques that are automatic fusion, and this is done with an active patient tracker that is located up to the skin of the patient during the CT or MRI procedure. There's no consensus for the best technique, and there's no proven superiority of one together to the other. Nevertheless, basically, we are very much comfortable with the automatic fusion using this active tracker technique. So cognitive fusion has clearly advantage because it's very simple, it's fast, there's no need of any additional equipment, but also require a quite extended training, a long experience, a long learning curve. So basically, we're using much more and more the automatic fusion techniques. So in this situation, we just combine the CT or MRI, most cases are CT guided techniques. So we combine ultrasound and the CT information, and then we just fuse this technique, these two techniques for better guiding of procedures. For this, we need electromagnetic field generator, and we also need a transducer with the magnetic sensors and of course a graphic interface. So if we look on a few cases, I'm very happy to share with you these procedures. Let's see first a patient with the incidental discovery of a renal mass during prostate cancer staging, and this man has some chronic kidney disease. So this is a very atypical mass that is sitting at the lower pole of the right kidney, and you see on the CT that was performed for staging the prostate cancer, this very large mass, and you see it looks like a cystic mass with some component inside. And after injection, you see that the mass is really homogeneous and poorly enhanced. So basically, the first step is clearly to say or to identify or characterize the mass. And if you very carefully look on the side, you can see that these areas are slightly enhancing. But is this so hemorrhagic cyst, or is this a true tumor? So basically, the first step is clearly to use the contrast enhanced ultrasound. And with these techniques, you can see how well we can detect the solid vascular components of this lesion that is not anymore hemorrhagic cyst, but the hemorrhagic necrotic renal tumor. And this is a true renal tumor. And that was not very well seen during the CT examination. And these are some reformats. And for biopsy, of course, you should be very careful on the location for the bowel structures that that are sitting, on the path of the needle. So for these, we decided to do the biopsy under fusion guidance, and this is exactly what you see on the left of your screen. There are these fusion image, and we see that we are on the right page, and we can fuse and still use contrast enhanced ultrasound. And we identified the solid components of the lesion, and then we will insert the needle under the guidance and perform the biopsy exactly at the site of the solid components. And the first biopsy procedure was successful and basically revealed the presence of renal carcinoma. This is a necrotic papillary carcinoma. But look at how well we can see the needle track and also how precise can be the biopsy. And this is very important in a patient that we don't want to repeat the biopsy procedure because of a failure, because we only get some necrotic specimens. When we do ablation, and this is particularly true in the side of the kidney because it's very lateral and the kidney is quite much moving, you see that we can combine CT and ultrasound information all together to be very precise on the location of the cryo needles. And if we are very precise, of course, we can be very safe. And you see that the needles, each of the needle, we see extremely well the path, the tip of the needle, and the tip of each needle can be inserted in a very precise way. And this is the result after 9 minutes of cryoablation technique. And of course, you see here the ice ball with ultrasound, and the ice ball with ultrasound was really covering the entire lesion. So registration using anatomical markers is not dead technique, of course, but much more now moving to automatic fusion with active patient tracker is a safe and very rapid technique. And in the case of discrepancy, you can add a few points just to correct a translation on the image, on the ultrasound image. So basically, it's a simple technique, it's fast, and it's accurate. So it's very helpful when we are performing complex ablation techniques. Of course, there are a few tricks in the way we set the system, and this is particularly true for the electromagnetic field generator. This generator should not be too close from the CT gantry, and we should try to avoid any metallic material close to the generator or close to the ultrasound transducer detector. So my recommendation is to be at least 50 centimeters distant from the gantry and raise the patient, adding some additional mattress on the top of the CT bed. The active tracker also should be located in a stable area, probably against bone structures. So if you are following these advice, I think you will get very, very good results. So in my conclusion, I would like to insist on this very interesting move of having premium imaging features reaching Arieta 750 for diffusion of interventional procedure and improvement of guidance. Basically, it is a pity to see that in most departments, the very complex interventional radiology procedures are performed with low-end system that will not provide sufficient guidance quality. So this system really has a very good B mode, as I hope I had convinced you. Easy visualization of the knee tip, good Doppler and micro Doppler performance, and CUSN fusion capabilities. And you see in this case how accurate is the placement of the needle and the biopsy taken at the right area, that is the only solid portion of this necrotic papillary cancer. Automatic fusion with this active patient tracker is a very simple, it's fast and accurate technique. And now it is possible to combine CT and ultrasound information for detection of isoechoic or non-visible lesion at ultrasound, having a good treatment planning with the new routes for putting our electrodes. Procedure duration is reduced, and we know that CT is a very busy imaging modality with a long waiting list, so if we can do it better and with no radiation exposure for both the patient and the medical staff, I think this is a winning situation. Thank you very much for your attention.
Thank you, Professor Correa, for your time and for the nice images you have shown to us and to share your experience with Arieta 750. It's clear that the fusion imaging improves the time management and the patient care. We would like to ask you if you think this tool would be a valuable tool for beginners in interventional radiology.
I think that this is a key question, because education in interventional radiology, as probably it is for surgery, is a key point, and training should not be at the depend of the patient quality management. So fusion is exactly moving to that side. Probably in a very expert, hands. It's not so much mandatory for simple cases, but for very complex cases or for young, beginners, I think this is a very elegant way to improve both patient management and patient care.
Okay, thank you. And would you think among other abdominal organs, such as liver, pancreas, spleen, do you think the fusion imaging will be also an interesting tool, a valuable tool?
Oh, of course. So basically, I focus on the kidney, because kidney is such a moving organ that is very difficult to treat or to drain or to biopsy. But of course, these apply to spleen procedures. It applies, of course, to a much bigger organ and a bigger indication that is liver lesions or drainage or interventional procedures, as well as, I think, in all organs in the abdomen. But the kidney has its own limitation, that is, it's a small organ that is moving quite much.
Okay, thank you very much for your answers. I will pass the word to Anne-Laure.
So thank you very much for these two very, very interesting clinical presentation. If audience has any other question, please feel free to contact us and we will answer after the webinar to all your questions. Thank you very much. Bye-bye.
Thank you.